Good morning, good afternoon. Good morning, good afternoon, good evening to everybody who has joined us for this exciting webinar on accelerating digital health solutions to deliver universal health coverage post-COVID-19, possibly one of the longest titles ever for a webinar, but a very important one because we have seen through COVID-19 how important digital health solutions are for universal health coverage. And we do have some catch-up work to do here. So our great thanks goes out to the co-chairs of the group of Friends of Universal Health Coverage and Global Health, the permanent missions of Georgia, Japan, and Thailand, for their support, and the World Health Organization, and of course UHC 2030, to have taken the initiative for this important discussion. I'm particularly happy to be here with you today for two reasons. One is that until recently, I was co-chair of UHC 2030 and was able to be actively involved with many of you that are here and your representations in leading to the successful high-level meeting on universal health coverage, which was a breakthrough. But still, I would say we have more thinking to do about the digital dimensions of what we discussed at the time. My second reason for being here is that I am the co-chair of a Lancet Commission on Governing Health Futures, growing up in a digital world. And here too, we are looking particularly at digital health solutions to deliver universal health coverage. And we worked on this commission over the last 2 years, and you can well imagine how much that has been influenced by the COVID-19 debate. So it's my great pleasure to welcome all the ambassadors, all the delegates that are here and will contribute. I'd like to say that there will be the opportunity to pose questions to the panelists. And we'd like you to please use the Q&A function to put forward any points or questions that you might have. That will be easier for us. And with the panelists, I think we can then also use the raise hands function if you feel that you would like to respond to a particular point. I'm sure after nearly 1.5 years of webinars of all kinds, sorts and sizes, we'll be able to manage this well. So without further ado, I would like to invite the permanent representatives and of Thailand and of Japan to give their opening remarks to this webinar. And I believe the agreement has been that His Excellency Kimihiro will begin.
Hi, this is Kimihiro speaking. Do you hear me?
Yes, perfectly.
Okay, great.
Thank you.
Well, I would like to begin by welcoming the members of the group of friends and thanking the distinguished speakers and panelists for participating in today's event. Well, the outbreak of COVID-19 has made us all aware of the need to invest in global health, global public health, and achieve universal health coverage. And in this regard, as WHO Director General Dr. Tedros has repeatedly stated, harnessing the power of digital technologies will be essential for achieving UHC. As I'm sure you are aware, digital health has been noted for several benefits, including, for example, improving access to healthcare services, especially in hard-to-reach areas through telemedicine, or improving the safety and quality of healthcare services and medicines, or reducing the cost and increasing efficiency in healthcare service delivery, and improving knowledge and access to health information, not only for healthcare professionals, but also for patients and communities by using smartphone applications. And all of this is expected to contribute to the achievement of universal health coverage. And from this perspective, Japan has been making efforts to promote international cooperation on digital health in developing countries through JICA and other organizations. In Bhutan, for instance, JICA has recently implemented a project in cooperation with UNDP to introduce telemedicine technology. The project uses mobile cardiotocography devices developed in Japan at hospitals in remote areas. And we're also cooperating to improve maternal and child health in the country. And in the area of infectious disease control, including measures against COVID-19, digital data from smartphones is used to track and analyze whether individuals have had any contact with confirmed patients in the past 2 weeks, which is used for active epidemiological surveillance. Furthermore, vaccine safety analysis is conducted by analyzing accumulated vaccination history and digital information. Today, I think we are going to hear presentations on digital health-related applications in Thailand, the digitization of northern child health handbooks in Palestine, and we will also be hearing from Health Tech Venture, which aims to improve healthcare in developing countries using digital technology. So I myself is very much hoping to learn a lot from today's speakers and experiences of other member states. I thank you. Back to you.
Thank you very much, Your Excellency. And let us thank through you, Japan also, who's been an unwavering supporter over a very long period of time now to the agenda of universal health coverage. And we have seen during the COVID-19, and we will continue to see, the importance of linking the UHC agenda, not only with the digital agenda, but also with a human security and a health security agenda. So this will continue to be incredibly important. It's now my great pleasure to turn to His Excellency, Mr. Vitavas Srivihok, the permanent representative of Thailand to the UN. We had the pleasure of meeting in preparation for the high-level meeting. Welcome, Your Excellency.
Thank you. Good morning from New York, and thank you for joining us today to discuss how we can accelerate digital health solutions to deliver UHC after COVID-19. Despite having to postpone the event, Thailand is proud to be working with the other co-chairs of the group of Friends of Universal Health Coverage, WHO and UHC 2030 once again on a very important topic. The COVID-19 pandemic has forced us to adapt to the rapidly changing circumstance to ensure the continuity of business, especially essential services like health and education, which are most needed in such challenging times. Digital technology has proven to be a game changer where physical movement is limited. We therefore believe that digital health coupled with universal health coverage can serve as a key pillar in our recovery from the impact of COVID-19. Thailand is a strong advocate for the strengthening of health system and resilience in order to achieve a sustainable recovery, to accelerate progress on SDG, and to truly achieve health for all. Investing in digital tools and bridging the digital divide help provide the means for development, including in raising health awareness and even delivering health services. This can be the solution to many, in particular, low and middle income countries. The political declaration of the high-level meeting on universal health coverage in 2019 highlights the role of digital health tools in empowering patients, which Thailand believes would also complement our ongoing efforts to empower communities in accessing and delivering health services, such as through our village health volunteer scheme. We have seen many examples of utilizing digital health tools in many places around the world during the COVID-19 pandemic, which we can learn from and build on. That is why I am looking forward to hearing the different experiences from our distinguished panelists today and to learn from participant views during the open discussion. And I wish everyone a successful event. And thank you, Madam Chair.
Thank you very much, Your Excellency. And of course, Thailand has been a model to many of us for UHC development at the national level, and particularly the participatory approach that you have chosen. I had the pleasure to attend the People's Health Assembly on various occasions, and many countries look to that model to try and see how they can take that forward. So thank you again for these two introductions and highlighting the importance not only of UHC, but exactly the digital dimensions that we now need to take on in much greater detail and with much more energy and speed than we have probably done over the last few years. And this is also what our speakers on the panel are going to take up. We will first hear from the World Health Organization and have some more scene setting on what we would like to achieve. We will then have two national perspectives from Thailand again and from Mexico. The very, very important application in a humanitarian setting, something that is becoming increasingly important as migration continues throughout the world. And very importantly, also a private sector voice. And we'll be able to bring that together and then have a discussion. So first of all, I'd like to turn to Dr. Garrett Mehl. He is the Unit Head of Digital Health Technology at the World Health Organization. You all know that WHO has now a digital health strategy, has been developing smart guidelines, and has a number of digital health initiatives ongoing. And Garrett is going to give us an overview and some direction as to how WHO sees this interface of UHC and digital health. So over to you, Garrett, please.
Thank you very much. I'll share my screen, and thanks again. It's a real honor to be here. And I will, let me know if you can see my screen.
Yes.
Terrific. Thank you so much. So in late 2020, WHO unanimously established the global strategy on digital health. And within that, there are four objectives that I think you are all very familiar with. One is focused on collaboration and knowledge transfer. The second is focused on digital strategy implementation. The third is on governance. And the fourth is on human-centered health systems and the use of digital to achieve both the WHO global program of work, but also achieving universal health coverage. And I'll focus primarily on strategy for recognizing that each of these different elements are critical to the implementation of digital health. For those of you, I'll just go back to really the essential elements of universal health coverage being coverage, quality, and affordability, and that digital health is used at country level in order to ensure that these challenges that are recognized to be issues such as poor demand for services or failure to follow guidelines or commodity stockout can be addressed using digital health approaches and digital health systems. Within the universal health coverage framework, we look at issues of quality, demand, supply, accountability, and in some ways, digital can help address the gaps, the barriers, or the bottlenecks that we commonly find in health systems. And by applying a variety of different uses of digital health, we can help ensure that we can both achieve universal health coverage and ensure that accountability and other aspects of the health system are addressed. When we consider digital health investments, it's important for us to think about what are the appropriate digital health approaches and systems for the health areas and for the users. Secondly, we look at what is the, how do we ensure that we can include appropriate health and data content that is consistent with recommended practices such as WHO clinical guidelines, interoperability standards, and common data sets and indicators. And lastly, that these systems are implemented effectively using training, monitoring, ensuring that financing is appropriate, and that through institutionalization, we can ensure scale, impact, sustainability, and interoperability. The first area I'll focus on is really ensuring that we identify the appropriate digital approach. When we recognize that there are inefficient supplies of commodities, there are specific strategies that can be used. We call these digital health interventions, and that these can be applied through systems like logistics management to overcome those barriers that that I noted in the previous slides, to ensure that there is appropriate stock levels and that the systems are adequately populated with commodities and supplies. In implementing these systems, we look at the health and data content, we look at the appropriate use of functionality of digital health, and we look at whether or not the systems are going to be appropriate to scale at a national level. I include guidance here, for example, the National E-Health Strategy Toolkit that WHO and ITU developed, and recognizing that there is an importance of the enabling ecosystem to ensure that these different, not just the system itself, the digital system, but that there's an appropriate governance and infrastructure and training and other aspects in place. The guidelines that I mentioned around, well, the WHO developed in 2019 really talks about and recommends 10 different approaches to using digital health that are evidence-based. And I include this here as something that really focuses on different functionalities and different systems that can address the quality, coverage, affordability, and equity issues that are really paramount to achieving UHC. This set of recommendations on the right, you see, such as birth notification, stock notification, targeted client communications, are recommended for use on the basis of the evidence and the systematic reviews that WHO conducted in order to ensure that the digital health approaches have an evidence base behind them. For example, within the COVID response, we find that telemedicine is being used, and it is certainly something that is recommended within the guidelines, but in order to overcome the barriers, geographic barriers of access of services between clients and providers. And there's implementation guidance within the guidelines themselves, as well as an accompanying implementation guide called the DIG. We also want to ensure that there is fidelity of health and data content independent of which software systems a country chooses. We call these smart guidelines. And this is really a focus on what is the recommended digitized data and health content per health program area. The smart guidelines support a paradigm shift in that they systematize and accelerate the consistent application of health interventions globally through digital solutions by identifying the appropriate functionality and the appropriate data content. Smart guidelines include examples such as antenatal care, family planning, and the recent or soon to be released digital documentation of COVID-19 certificates, in that they ensure that as a country, you're able to identify or incorporate the appropriate data and health content into the digital systems that you may already be using. They provide a generic starting point to ensure interoperability and that you're going to function ways in which you're able to get the most out of your digital systems. The third area that I mentioned around ensuring adequacy implementation for digital solutions is really a really important area to ensure that the fidelity of deployment, whether it's through monitoring, training, integrating the systems within a national architecture and using interoperability standards, really can help ensure the fidelity of that deployment and ensure that you're getting the most out of your digital investments. It includes a recognition that there are a number of different areas in a digital investment, and that the investments should be appropriate to the maturity of a country, should recognize what may already be in place within the country, and recognize the importance of governance and the data use culture within the application of the digital interventions within systems, and really provides a stepwise approach to ensuring that a country is able to recognize what may already be in place, identify the needs that the country may have by program area, and put together an adequate implementation plan that is costed appropriate to the setting and the needs of the country. This stepwise approach of the DIG is within a broader ecosystem of other guidance and guidelines that the WHO has put out, but that also other UN agencies and other technical bodies have also released. And so in this presentation, I provided an overview briefly of SMART guidelines, of the digital investment implementation guide, as well as the WHO guidelines on digital health interventions. Thank you very much.
Thank you very much, Garrett, for giving us this overview. Of course, this is just the starting point, and we encourage everyone that is part of our discussions today to dig deeper into this extraordinary amount of work that has been done in the context of the World Health Organization, together with many experts from around the world. And of course, also, which is complemented by materials from the regional offices that can be then even more applied in specific contexts. And thank you for that focus on what you've called the enabling ecosystem, because the thing everyone wants to get away from, obviously, is taking technological solutions to a place, to a country, to an environment, without really ensuring that it is supported, that it can be built systematically and long-term, and that it can be scaled up. So many of these things, I think, will also come as we hear from the following speakers. So let's hear from two countries, two national perspectives. First of all, we will hear from Thailand, from Dr. Lalitaya Kongkam, who is Deputy Secretary General, National Health Security Office in Thailand. Welcome. Will you unmute yourself, please?
Oh, sorry.
Yes.
Can you hear me?
Now
Yes.
we hear you. Thank you.
Thank you. Good evening from Thailand. Your Excellency, Permanent Representative of Georgia, Japan, Republic of Korea, and Thailand, distinguished speaker, moderator, and delegates. On behalf of the National Health Security Office, I would like to express my sincere gratitude for inviting us to the side meeting of high-level political forum. I would like to share my slide. this topic for me today is the digital health solution for Thailand, universal health coverage, and the pandemic of COVID-19. This is the outline of our presentation today. And as you know that Thailand achieved the universal health coverage since 2002. We have three schemes, the UC scheme and social security scheme and civil servant scheme. It's cover 99% of the population. We have 66 billion people. And during the COVID-19, all health-related service will cover for everyone in Thailand. Both Thai and non-Thai people will receive the free screening and treatment through our mobilized additional budget and stakeholder participation. We also have a digital health master plan for UC scheme. We aim to improve our health access and our effectiveness of the health system in UC scheme. The next slide, this slide, I will show you that how we implement the digital health in our system. This is the mobile application for member of UC scheme. We adopt the technology for the better health access. In 2020, we launched the mobile application for more convenient registration procedure and access to the health promotion and prevention service. This application provides users with health benefits information and their eligibility for the medical service. They can also change the health unit by re-registration through the application. And during the pandemic, the application makes it convenient for the patient for their booking and decrease the risk of exposure to the COVID-19. Currently, we have the system to supply our medical supply via the VMI system to deliver medical supply and medicine for the end-stage kidney disease patient and for the chronic care patient by collaborating with the Thailand Post. And during the bad disruption of the pandemic period, it serves as a catalyst for the adoption of modern-day internet-based communication technology, such as telehealth and telemedicine. So we introduced telehealth and telemedicine into our system to decrease or reduce the hospital congestion, as well as to reduce the risk of the patient, of the people to expose to the COVID-19. This slide, I would like to show you our new medical service. We collaborate with the National Cancer Institute of Thailand. We launched Cancer Anywhere policy to improve the quality of cancer care. We upgrade our benefit to the patient and improve the convenience of the patient to access to the health system. So the patient can receive the good service and can shorten the waiting time of the patient to get the treatment. We also work with the Ramatipadi Faculty of Medicine, Mahidol University. We pilot 27 public hospitals for the home chemotherapy for colon cancer patients. And we aim to reduce the demand of inpatient admission and improve cost-saving treatment effectiveness compared to the hospital base. This slide, I will show you our customer protection system. We have NHSO 1330 hotline. The hotline serves as the customer protection So we have many systems to serve our customer and to protect their right to get the treatment, to get the care for our benefit. During the pandemic period, the infected people who are asymptomatic or have mild symptoms will be placed into home isolation and community isolation. If they are not the people who their hometown outside the Bangkok, they can request us to send to their hometown by contact with their hospital in the hometown. This is the new service of our system during the pandemic period. We create the dashboard for the home and community isolation. We get the information from our hotline system. The information will map the patient with their nearby primary care unit. Then the family physician will receive the information of the patient, and they can make online consultation to provide treatment for the patient, as well as we deliver food and medicine to the patient during isolation period. So the digital health is very important for UHC. Our aim to strengthening our UHC. So the next period, the application and the wearable disease will be the next provide for our patient. And we continue to adopt more digital health solutions to enhance health outcomes, self-management of patients, and the advancement of the UHC. So this is our presentation. Thank you.
There we go. Thank you very much, Dr. Kongkam, for that presentation. And thank you again for particularly highlighting the patient benefit side of digital health. Some digital health developments one sees are not that patient focused, as you have tried to indicate to us. And also watching and listening to your presentation, I was thinking to myself that how advanced your system already is compared to some of the experiences we've had in the part of the world that I live in. And I think there's a lot of learning to be done there. And I hope we can also encourage that through this event. So I will now move on to Mexico, and I'd like to welcome Dr. Adrián Pacheco López, who is the Acting General Director of the Center of Excellence on Health Technologies and the Director of Telehealth at the Ministry of Health in Mexico. Please, the floor is yours.
Thank you so much, and hello to everyone. Good morning from Mexico. I'm going to share my presentation just a little bit. Can you see my presentation now? Perfect. Well, digital health has been part of our lives almost from the same moment that the internet allowed us to access health information. At the beginning, was developing gradually and slowly, but in the recent months, in a very fast way. Also, like any technology, its full adoption takes time and requires adaptation of some clinical process. Many of us do digital health processes every day in our daily work. A good percentage of the population use digital health tools, a solution to a lesser degree, but with a constant increase. However, if we look at the health system in a holistic and comprehensive way, the adoption of digital health could be still a long way off. I know we all understand the broad scope of digital health. However, my comments in this webinar are just from the telemedicine and telehealth perspective. In Mexico, first telemedicine projects were developed 20 years ago, and first national program was created in 2008. Since then, the development of new devices, medical equipment, telecommunication infrastructure, processes, and regulations have been changing and developing to improve service through these tools. Our first projects were focused on addressing our problem of lack of specialists in rural hospitals. Original initial objective was to support the first level of care in the most remote areas, but several changes made us implement programs in hospital units not so far away to provide more support to the second level of care. Teleconsultation and remote image interpretation were the main service supported by telemedicine. Today, the National Health System is carrying out an organizational restructuring strategy. I'm sorry for the noise you are hearing right now, sorry. Okay. Today, the National Health System is carrying out an organizational restructuring strategy, including the way of delivering health services. In this new approach, digital health and telehealth plays an important role as a tool for coverage of health services. The focus of the first level of care, especially primary health care. Thanks to technological advances and adoption of new forms of communication between people, now it is possible to use devices and systems to allow health workers a better collaboration and communication in real time, no matter where they are. This new approach allows us to go beyond the limits of medical units and to establish closer contact with patients. It is necessary to incorporate human resources with profiles with high knowledge of digital skills, human resources who know the new forms of interaction using electronic platforms. We must stop thinking only about strict models of vertical communication, where the doctor was the only one who can comment on the patient's health. Today's world is much more horizontal. Health institutions must understand the new role that they have to play. Last year, digital health tools were an important element in the face of the pandemic caused by coronavirus. Supported by digital health strategies, we were able to maintain a good percentage of continuity of medical services from transmissible and non-transmissible diseases. When the pandemic started, many patients and healthcare workers were already familiar with the use of digital tools. They just adopted some process and quickly found an effective way to maintain the continuity of their treatments. But another important number of patients and doctors that had refused before to the use of digital technologies faced a drastic change. They had to walk a rough learning stage, fast but with good results. After more than 20 months, digital health situation has changed considerably within the national health systems. It is no longer just an idea or something that has a potential for help. It becomes a necessary tool. Of course, we have to learn quickly how to manage it correctly and to look for obtain the best benefits for patient and health organization. There are still many challenges to overcome. It is necessary to develop models that being flexible enough to adapt them into new scenarios, improve digital capabilities of our workers, establish processes in accordance with new digital trends. I appreciate this invitation, and I believe international collaboration, exchange of experience are essential to walk into this innovative health practice. Thank you to everyone.
Thank you very much, Dr. López, and thank you for highlighting a couple of things. First of all, how important it has been in COVID-19 if there already is an infrastructure and some experience of daily use by patients and by professionals. because then in the COVID-19 situation, that was much easier to build on. But also you have again highlighted the enormous acceleration that COVID-19 has brought to the digital sphere, and that now there is a big challenge on how to use those experience in the UHC space, and again move from a vertical model to a horizontal participatory model that really involves people, and that covers, as we also heard from Thailand, a wide range of issues. We've sort of been focusing now through COVID-19 on the infectious disease side of things, but particularly the Thai example has also shown us the importance of cancer care. You have highlighted the maternal and health childcare issues. So I think this acceleration will be a challenge that we need to take up, and sensible integration into existing models. Now, we will move on to another big challenge, as I indicated earlier, and that is the application of digital health in humanitarian settings. There's been great development in this field through a range of organizations that are active in the humanitarian space. Through our Lancet Commission, we were also able to look at this together with the International Federation of the Red Cross and the Red Crescent. And I'm sure there's many other such initiatives. Today, we're going to hear from Dr. Akihiro Seita. He's the director of the medical office of the Relief and Works Agency for Palestinian refugees in the Near East. And I'm delighted that he's here with us today to show the very complex situation that we face in digital health in humanitarian settings. Please, Dr. Seita, the floor is yours.
Yeah, thank you very much. Do you hear me and do you see the screen?
Perfect, perfect.
Good, thank you very much. So thank you very much, Madam Chair. And my name is Seita, working for the UNRWA, or we call it UNRWA. It's a very specific agency developed in 1950 to support the Palestine refugees. And we provide primary health care in these 5 fields of operation: Jordan, Lebanon, Syria, West Bank, including East Jerusalem, and Gaza. And as Madam Chair mentioned, that I start with the COVID-19 because it is still very vivid and it's still a major problem we face and live in. And digital health is a critical part of our response to the COVID-19 and to move to the post-pandemic COVID era. And just to bring that notion that how the COVID bad in this part of the world, that you can see that the highest peak happened this year, not last year, March, April, May. We had the highest number of COVID among the host community. And then that is also the problem. And then the same for the refugee community. They always have the highest one. So now it's up to the end of May, but it's going down. But we have an increasing report of numbers of Delta variants. And the vaccination coverage is still maximum 25% in Jordan, 10% in Lebanon and then Palestine, and less than 1% in Syria. So that we are deeply concerned about the future of the health of this part of the world and the vulnerable Palestinian refugees. So when the COVID came in, what we did, as I said, that we have 140 health centers in the 5 fields of operations and providing comprehensive primary health care. These 4 photos show what we have done. One is that the COVID triage, so that to make sure that the people coming to health centers, we differentiate the patient flow, those who have a fever or cough, to the rest of the people coming to this one. And secondly, that when the patient cannot come, we deliver the medicines to the homes of the particular those with diabetes, hypertension. This number is from Gaza. In Gaza, that the home delivery medicine took place 170,000 patients with diabetes or high blood pressure. And then that the digital health is played a very critical part of this. I don't know if you can see this. This is the, This is the MCH maternal child health application inspired by the Japanese experience of the hard copies. And so the mother can have now access to the MCH, maternal child health, babies information. So even from home, they can communicate with us. We have almost 180,000 mothers download this application now. It helps. And then also telemedicine. We have electronic medical records covering all the health centers, including Syria, Lebanon, West Bank, Gaza, and Jordan. And then around 3 million patient records. Many health centers are digitalized completely. And based on this, we introduced the telemedicine. And so the health center was to respond to the COVID. Two things were critical. One is to identify people with the COVID infection. So that with the help of Minister of Health in Gaza, we introduced a rapid antigen test for the COVID-19. And this is a 13-year-old girl. I took it last month, just before the war. I was in Gaza, and this girl was positive for the COVID-19 test, as we can see in the photo. And the right side is telemedicine, that this lady is taking care of the telephone consultation. And we introduced ICD-11 throughout the telemedicine and electronic medical records, and she is taking phone and answer to the questions. And that works well, because this is a comparison, this early analysis of what we are doing now in one of the clinics in the Gaza, and then comparing to the pre-COVID 2019 and the current now. By chance that the number of visitors are almost the same on those days. And then that now that it is clear that 1/3 of the medical consultation, we are dealing with the telemedicine. And then that the 260 dealt with the COVID triage get placed, and the 470 is a general practitioner we have. And so that the digital health help us. One is that reduce the crowdedness in the health centers, because that is still critical to avoid any crowdedness in the health center, but also take care of the patient whom we can take care of remotely, like ordinary cough, ordinary fever. So this kind of patient may come to the clinic to get the medicine, simple medicine. Then of course, critical patient, they will continue to come. So I shall leave with the two technical slides next. So by doing this, our policy in the last year, 2020, is that to focus those most in need. Medical consultation reduced, but the family planning users continued. And then, but to maintain the qualities, diabetes control rate remained the same. And the number of antenatal care visits decreased from 6.0 to 4 point something. However, this is still above the WHO's classical recommendation more than 4 times. And the health outcome, which could be too early to see, but maternal deaths or the deaths among the NCD, diabetes, remain the same. So it seems that the digital health help us to maintain the services by focusing on what we need. At the same time, I'll show another slide, but we have a quite large number of staff infected, or almost less than 20% of health staff infected with COVID, because we were frontline workers, although we put all the PPE and the IPC recommended. And the mental health, this is the case in Gaza again, that we have more cases of people who are seeking mental health, which we introduced. And among many of them are female, and some of the kids, and the suicide deaths were reported. Because suicide is culturally or religiously taboo in this part of the world. But the COVID-19 put us in a situation that people may have no choice but. And the food insecurity could be the case. We are also analyzing this. So having said so, and also this is another part of digital health, we introduced a staff monitoring dashboard. And you can see that the number of UNRWA staff infected, unfortunately. And as a matter of fact, in this during the last 1 year until now, and this is a daily updated, so we can monitor. So digital health is important, not only the taking care of the patient and the communities, but also taking care of the staff. UNRWA is a quite large organization with 30,000 staff, with 700 schools and 140 clinics. So that the staff care is very important. And we do everything we could do, including promoting the vaccination. But this is a reality of the frontline workers. And it's important for the digital health or digital technology to monitor the people we need. So what's next? Having learned this one, this is our new policy. So it's a bit schematic graph. But what is important to make sure that our primary healthcare centers in the humanitarian setting to maintain critical services. One is our center is COVID resilient, and then this includes rapid antigen tests and COVID triage and the vaccinations. And then secondly, that we need to do person-centered family health team or family medicines. and the family health team, and the mental health, gender-based violence, which is also on the rise. And digital health or digital transformation, which we are promoting, will be there to help this. Electronic medical record is important to monitor all this transaction of services, including the logistics management of the medications, and telemedicine and the smartphone application, thanks for the donors that we introduced, in particular Japan and the US in the past. And so that the smartphone application is the best way to communicate with the health centers, and so that we can still maintain health center less crowded. And also that we have many other applications in UNRWA, including RISS is registration ones, and EMS education, SAP entrepreneurial management system, and all others. So we can provide the connected ones. So last slide, what I learned last year till now. It's not a venue to discuss vaccination, but the vaccination is critical. And then that without vaccine, sorry to say, no control, no primary care, no UHC. That's my honest feeling. And I appreciate the whole entire world support to the people who have less access to the vaccinations. Like Garrett said, maximum Jordan 25%, Syria is 1%, Lebanon, Palestine is only 10% coverage. And the importance of innovations. Telemedicine works, and the rapid antigen test works, and the MCH application works to make a connection with these clients, even in the humanitarian setting. MCH applications, many mothers send messages to us asking what is the next appointment, or all these kind of things. And that is important to prepare COVID resilient primary care. And it's important to work to develop not only the COVID pandemic era, post-pandemic era universal health coverage, but most importantly for us, the post-COVID pandemic era primary care strategy. That's very important. And but at least that, like my previous speaker mentioned, COVID-19 realized what kind of world we are living in. One of the Palestinian refugees in Lebanon said, under the very difficult current situation of the economy, COVID and everything, I would either die of COVID or poverty or run away. And this is not, this is a very serious statement. I have no way to respond to this one. But still, last but not least, this is what I want to say the previous speaker mentioned. COVID brought us together. I feel that we are much more closer before the COVID time, attending many international conferences, meeting many people. So hope that everyone is vaccinated, COVID is gone, and we can meet again physically all together. Thank you very much.
Thank you very much, Dr. Seita, and thank you for ending on a positive note, despite all the enormous problems that you and others are facing. I think what was interesting also in what you presented is that, of course, going forward with different digital health solutions can also allow us to look beyond the narrow understanding of primary health care and universal health coverage. You indicated the food security issues, the gender violence issues, and of course highlighted mental health issues that are becoming ever more important. So I think, you know, really having the kind of UHC and PHC understanding that was with us from the start, which is more than just health services proper, but the integration into many other policy arenas, the participation of people, etc., is really, really important. And I use this point for a little bit of lobbying for the key asks that UHC 2030 developed in preparation for the high-level meeting in 2019, which include a whole number of these issues. And where now, you know, we spoke in those 6 key asks about the need for a social contract, seeing UHC as a social contract. And so many people now have been saying that we do need a new social contract based on all the experiences that we have had in COVID-19, which is obviously not over. And what role also digital solutions play within such a social contract in terms of solidarity and a trust architecture that we need in order to move forward and guarantee access. So thank you for highlighting also some of these elements. And as the last speaker in this section of our program, I'd like to invite Ed Booty, who is the CEO of Reach 52 and is part of the UHC 2030 private sector constituency that is getting ever more active, which is very good to see. And he will highlight some of the private sector's contribution to this important agenda that we have. Please go ahead, Ed.
Excellent. Thank you for that introduction, and thank you for some wonderful presentations so far from other speakers and honourable guests. I'll just set a timer on myself so I don't talk for too long, and don't want us to run over. But yes, as mentioned, I'm Edward Booty, founder and CEO of Reach 52, and we're a Singapore-based company focusing on reaching the 52% of the world, or 3.7 billion people, that lack access to healthcare. And what we're trying to do, almost all of our model on the first slide, is we basically train community health workers or independent people to be agents, and they use a tech platform that we've built to really connect their own communities to health products and services. What this means in reality, and sort of to go through it all in a bit more detail, and then we'll talk about some of the collaborations that we've done with private sector, as we definitely, structured as a private sector intervention. But generally we work in communities that are at least 1 hour away from the nearest health facility. So we're in 5 countries at the moment, and we do not work in urban areas. We go to the very rural, lower income areas of countries where healthcare access is low to non-existent. We then train the health workers in that community to use a tech platform that we've built, and they basically go and sign up everybody in their village and collect data on the healthcare needs. Based on having the trained network of health workers and agents and having the data, we run very targeted screening campaigns, or screening and awareness campaigns. We've done a lot in NCDs and maternal and child health and hepatitis and HIV and financial literacy and financial protection. But really, yeah, train the health workers, collect the data, and run very sort of targeted, campaigns at the community level. And then lastly, we're also making available affordable, discounted private sector products. So we started with prescription medicines, but we've since also made available insurance, low-cost health and life insurance, as well as consumer health products as well, such as vitamins and feminine care and so on. And yeah, very actively working with private sector to also source discounted products that fills the gaps in the available government services and provides a sort of complementary integrated service. And we've talked a lot about patient centricity today, which is absolutely fantastic. And, I'm a true believer of it as well. And what we're now seeing is by training the government health worker, giving them technology, they can offer more relevant services, but they can also offer services from both public and private sector through a single channel, which ultimately is a better experience for them, given the heavy fragmentation that often exists in countries with significant private sector providers. People do always ask how we make money as a business. So we're sort of very proudly integrating private sector organizations to this model. So we work with large pharmaceutical companies, Johnson & Johnson, Novartis, Biocon, Gilead, and they fund 3 things really. Firstly, we share the health needs, so the data and insight in aggregate form to help people design their access programs. We then run awareness and screening campaigns with private capital funding some of that. And then we also look to source the discounted products from them as well, really looking to enable this marketplace approach of complementary services to government. In terms of where we are, we're sort of proudly a startup, if you will. We serve about 500,000 patients at the moment, working with 11 on-the-ground partners, about 4,000 agents across the Philippines, Cambodia, India, Indonesia, and most recently Kenya. So we're just starting to open up in Africa as well. And we have about 20 business partners that fund system strengthening and capacity building work. And we're distributing about 7,500 products in our marketplace model as well. And way beyond Reach 52, I took this from a report that many of you will have seen as it came out of this group, or more broadly from this group. But the private sector has, of course, been, incredibly critical in times of COVID-19, both in terms of maintaining critical supplies, increasing productions, producing the vaccines, running testing campaigns, both here in Singapore and, in the region and, of course, globally. And yeah, we've talked a lot about digital health today, but really having, access to data, doing risk algorithms to help find patients, providing the technology, providing the telehealth services has, very often been private sector supported or indeed delivered in its entirety alongside government partners at this, critical time in global health. And then just the last one, this is just a bit of a shout out for the State of UHC Commitment Report. We're I'll put the link in the chat after this, but yeah, for everyone on the call, the deadline has actually shut for the State of UHC Commitment Report. But on behalf of the organisers of this, I would just ask for any final contributions for this, and we can post the link in the chat shortly. And thank you all for listening, and sorry for being a few seconds over.
Thank you very much, Ed. I think that's an important complementary presentation to much of what we heard. Many of the other initiatives that we've heard always also tend to have the one or the other private sector contribution. And sadly, in this area, with all the positive presentations and contributions you have shown us, there is still the other side of the private sector in terms of misinformation, in terms of many of the infodemic issues that we haven't yet been able to resolve, neither at national nor at global level. And so I think working together, both from the private and the public sector, to address some of those other problems is absolutely critical in terms of moving forward with universal health coverage and dealing with many of the primary healthcare issues such as vaccination, etc., because we will have to address those kind of issues as well. So, and please, if you can still contribute to the State of UHC Commitment Review Project, please do that. All of us committed to UHC 2030 are very keen that many voices are heard there and can then be presented on occasion of UHC Day later in the year. And that, of course, is linked to many of the SDG 3 initiatives that are so important to all of us. I'd like to turn to our audience to please use the question and answer function if you have any questions that you would like to pose to our distinguished panelists, if there are any areas where you would like a bit more information. We are doing rather well on time, so I hope we can bring in some of those questions, and the preparatory team will help us organize them. So please use that function, one of the most important functions in these kind of virtual meetings. But it's my pleasure now to ask the discussants that are already on our list to give some input. And the first on my list is His Excellency Mr. Cho Hee-yoon, who is the permanent representative of the Republic of Korea to the United Nations. Can I call on you, Your Excellency? There you are, please.
Thank you very much. Thank you for inviting me to this very important discussion. But first, let me congratulate Georgia, Japan, and Thailand for hosting this very timely discussion. I believe this will be very helpful in overcoming the pandemic in all the countries concerned. A very substantial discussion, as I have watched it, and much food for thought. So not much to add, but with your indulgence, let me introduce a few things the Korean government has been doing. First, the Korean government has been very swift to introduce digital technologies in delivering effective public health services. For example, we have been trying to identify confirmed cases with new technology even with a blockchain COVID-19 vaccination verification system. I do not know what it is about, but all the experts here who are participating in today's discussion might know about it. Secondly, the Korean government announced the Digital New Deal strategy in July of last year. This was to pursue successful digital transformation in various sectors, including public health sector, such as remote healthcare, medical diagnosis, digital therapeutics, and epidemiological investigation. Finally, Korea has been also working on narrowing the digital divide and strengthening connectivity among those who are digitally less connected. Well, as for the result of these efforts, we can discuss it at another occasion organized by this group. So I look forward to another opportunity to engage with this wonderful group. Thank you very much.
Thank you, Your Excellency, and thank you for already suggesting that this might be an ongoing conversation given the importance of digital developments in universal health coverage. And thank you very much for raising the question of access and equity. And I will wait and see what the questions we get in the question and answer function. But it is one of the things I'd like to put to the panelists. How in particular are you ensuring that equity and access issues are addressed as people face different issues around participating in digital solutions, be that through access to infrastructure, to hardware, to literacy and other issues. So that would be very interesting to hear from you how you are dealing with that, particularly in your respective national contexts. It's my pleasure now to ask the second discussion. This is Ilona Gelb from the International Federation of the Red Cross and the Red Crescent. Please, the floor is yours.
Thank you, esteemed moderator, and thank you to the co-chairs of the Group of Friends of UHC, WHO, and UHC 2030 for organizing this event. Ambassadors, Excellencies, esteemed colleagues, COVID-19 has shown us more clearly than ever that we must embrace digitalization in the ways that we work and live. When used equitably and responsibly, digital health tools are powerful tools that make health systems and humanitarian responses more efficient and effective. As we are urgently called upon to implement universal health coverage, we must consider that digital health technology should be an enabler of healthcare provision in humanitarian settings and not a goal in and of themselves. As our moderator mentioned earlier, the report Enabling Digital Health Futures in Humanitarian Settings by IFRC, ICRC, and the Lancet revealed some of the following key findings that I'd like to share. First, bridging the digital divide is inextricably linked to implementing UHC, particularly as data collection, telehealth services, emergency communication, and medical records are increasingly digitalized. So we must consider that women, girls, historically marginalized groups, persons with disabilities, older persons, persons living in extreme poverty, individuals without regular access to charging stations, and communities living in rural areas may be more likely to experience digital poverty. And this means that not only might they lack access to digital health services, but that as we're collecting data digitally, they might be uncounted and unconsidered, which could really impact and impede the effectiveness of health and humanitarian responses. Second, technology built with human biases, such as implicit gender and racial bias, can deepen inequalities and exacerbate the digital divide when these technologies are rolled out. So to reach left behind communities, a people-centered approach must be taken, ensuring the holistic accessibility of each individual to the technology. Third, low-cost, low-tech digital health tools are useful and effective in humanitarian settings, but we need to overcome a funding shortage to scale up the development and implementation of digital tools in humanitarian responses. As we roll out digital tools to expand UHC and improve humanitarian response, we must maintain the humanitarian principles. Do no harm still applies digitally. This means ensuring privacy by design, data protection, and third-party due diligence. Without a principled and transparent approach to digital health tools, we risk further eroding trust in public information and institutions, and we hazard exposing affected persons to more harm. Using a principled approach, IFRC has expanded its digital health services in the COVID response via tools such as contact tracing, digital community feedback mechanisms, telehealth for mental health and psychosocial support services, risk communication on social media, blockchain technologies to distribute cash, and virtual training and capacity building for community health workers, staff, and volunteers. IFRC, the Red Cross and Red Crescent National Societies, and our network of volunteers are steadfast in our commitment to implementing UHC and reaching the last mile in health. Thank you all for your continued partnership in this endeavor.
Thank you very much, Ilona, for highlighting also some of the issues that we discussed in the series of workshops in preparing for the Lancet Financial Times Commission report. And I think they raised some of the concerns that are also starting to come up in the question and answer section. So maybe if I could take this or combine in a way what some of the questions are highlighting. On the one hand, there is the issue that I already indicated, how do we reach through digital solutions the hardest to reach? And what special effort have you undertaken in your national or your organization strategy to take that forward? That's one of the really big issues around governance of digital health. The other is, of course, the whole balance of digital solutions on the one hand and the whole issue of privacy, which of course, particularly in the health arena, is an issue that is absolutely central. And a third was, and I'll come back to that afterwards, Ed, a specific question to yourself that you might have seen as to who exactly you are working with in your context. Maybe if I turn, and I'll ask you to give very short responses. Maybe Garrett, if I turn to you first, how is WHO approaching these issues of, the real sort of access of the most vulnerable and hardest to reach, that some of these solutions, don't widen the health gap even more on the one hand, and on the other hand, are there specific recommendations you can draw people's attention to around the privacy issues?
Thanks very much. The questions are very interesting and appropriate. I think when we established the guidelines on digital health, we recognize that digital could amplify and ensure that health interventions are that it improves the health system, or it could really undermine it if the access and equity issues and the infrastructure issues were not adequately addressed. So we recognize that member states would need to recognize that offline access, that digital on its own may not be enough. It really needs to be seen as an augmentation, that traditional approaches may still be necessary to ensure that all populations benefit from the health services, and that that digital does no harm. And I think that comes into play when we think about the privacy issues as well. As health practitioners, we're wanting to ensure that individuals are empowered, that they have access to the adequate and appropriate information at the right time, but that information does not undermine their health in some way. And so considerations of anonymity, if data is being aggregated for monitoring purposes, become relevant. And there is personally identifiable information that really needs to be safeguarded and saved in an appropriate place, that where only individuals who really need access gain access. So privacy by design is very important here. So national policies become important, and the monitoring of their implementation in the case of digital needs to also take into account, and there needs to be governance around that. So I think with that, maybe I'll pause and just hand back to you, but I think they're really important considerations. Thanks.
Thank you very much, Garrett. Could I turn to you, Dr. López? How are you handling this in Mexico? On the one hand, the digital divide and reaching out to the most vulnerable, and on the other hand, this balance of ensuring privacy and building a trust architecture within universal health coverage.
Yes, of course, this is one of the greatest challenges. In one hand, we have to ensure the security and safety for the information for the patients, and in the other hand, we have to look for devices that are highly accepted. The access is not only the possibility to have interaction and communication with the patient and with the doctor. The access, it means to have a correct device, to have internet, a very good internet connection, and to have the ability, the skills to use the device. So those devices are the common ones, the ones that the people used to use for normal communication. So we have to find the way of how the people, the patient, use those devices, but in a safety way. It's maybe matter of engineers. It's matter of Garrett said before, policies, how you make the regulations, and how do you train health workers to be safety as possible on the process. It's a very difficult challenge.
Thank you very much, Dr. López. And some of you might know that the UN Special Rapporteur for on poverty and for the most vulnerable populations did raise the issue that through the wrong approach, and also the wrong approach to perhaps health data that are gathered, that actually there might be additional disadvantages that emerge in terms of control for populations that are already disadvantaged in terms to their access to welfare payments, their behaviors and other things. So it's a really big balancing act, as you indicated, around access, human rights, and access to good health care. Dr. Kongkam, how are you approaching this in Thailand?
For the marginal people, we work with the health volunteer. So the health volunteer can access to the digital health, because in all over area of Thailand, particularly in the health center, they can access the internet. So we work with the health worker and the health volunteer. The health volunteer can work with the people, and they can make the people access to the digital health in our country.
Thank you very much. Dr. Seita, are there special access issues that you encounter in your work?
Yes, I wrote my answer already, but the access to the special one, I think it's a digital device, very serious issue, but the place I work, that things are moving ahead. I think that they say when we started smartphone applications used with the help of the Japanese government, we did a survey, and 80% of refugees have smartphones, and that encourages us to move ahead. And then that they usually use WhatsApp and Facebook or such kind of social network for their day-to-day communications. Mm-hmm. And also that we have a e-health EMR that connecting 140 health centers with using local network. And we moved to cloud recently for the UNRWA in Geneva, and it moves very smooth. So I think on the ground situation, we're rapidly improving. So we don't need to be so desperate, but important that the most vulnerable behind. And I think it's beyond the health issue. I think we should talk to the government and telephone company to improve the infrastructure, and then that make sure that people have access to the telephone 3G, or if not 4G, if not 5G in the periphery, and then so that people can utilize the services. I think the reason I'm saying this is that we have 500 schools and the 700 schools of 500,000 students. And as you know, in COVID, many schools are closed and they moved to the telephone or digital learning or e-learning. It was very difficult because that, yes, 80% of refugees have a smartphone, but it could be one per house family. And so that how can we make sure that the 5 kids can use this one? And then so that that's also very vivid. And in that sense, I think COVID-19 is a very good opportunity for us in working the social sector and the health sector to raise the voice about have a good infrastructure. And so that everybody can benefit, and the COVID is a great opportunity. Thank you.
Thank you, Dr. Saito. And that's, of course, a call both to the governments, but also to the private sector. And, the cooperation actually between government and the private sector. So maybe, Ed, you have a view or two on these kind of challenges, while also perhaps giving a short answer to the specific question, who you specifically work with in the Philippines and how you work. So please, Ed, over to you. Some ideas of how we can use the resources of the private sector to move things forward.
Yeah, absolutely. I did answer that question in the chat just in the interest of time, but I mean, just to confirm, we have formal government partnerships at a national level and also subnational level. So formal MOUs and government partnerships, and we always host the data in the countries that we work in. I joke, as a sort of startup founder, I guess, putting that hat on, I was pretty bad at it to start. And we did build tech that needed the internet, and we had a patient-facing app and so on, as a logical digital health solution, and it didn't work, right? The internet was patchy and unreliable in the Philippines, even if it should be there, it cut out on when you needed it most. And to be honest, people aren't naturally health-seeking, especially when they're older, which is where you're more likely to have more comorbidities and so on. And on the first day we switched our tech on, we realized we had to rebuild it all, and we have since rebuilt it to work fully offline. We support Android version 6, which is about it's from 2013, so a very, very old operating system. We've built quite a lot around peer-to-peer syncing. So if I'm a health worker, say I've been to the town to collect some medicines and I've been online syncing, the latest health events, the screening campaigns. If I met my fellow panelists, in the village, they can sorry, someone's at my door. I don't know who that is, but hopefully that's not too annoying in the background. But you can actually all sync to my phone, basically. So as I've been online, you connect to my phone, you pull all the updates, all of our data backs up on each other, and we encrypt it on each other's device. And I always say some of the hardest things we've done is making our app very basic. We've spent way over a year making our tech incredibly basic, and the internet is a luxury that many don't have, but you just have to face up to that fact and just engineer around it. As Dr. López rightly said, it's a sort of engineering problem that you just have to cope with. But that said, if I could wave a magic wand, I think telcos and better payment infrastructure would be what I'd wish for in the broader enabling ecosystem, because we do have to accept that healthcare is out of pocket. We're moving cash as well, right? We have low tech, we take payments in cash, which is risk and cost and operational inefficiency. So if we could solve both of those two things, I think that's absolutely critical for digital health to thrive in low resource settings.
Thank you very much, Ed. Thank you to the panelists for these very, very informative responses. Thank you to the audience for your questions, which again, honed in on some of the most critical issues that we need to discuss in this context. And thank you to the panelists who are giving more detailed responses also in the chat to the people who are asking. I'd like to say that it was very helpful, first of all, to hear from all of you the ongoing commitment to UHC and the recommendations from the high-level meeting in 2019, the integration of the digital challenges and solutions into that concept of UHC, and probably also needing to be a bit innovative in our concept of universal health coverage. We've been, looking at the UHC cube that many of you will know and say, how in a digital age might we need to adapt that? And in our Lancet commission, we have been saying, how do young people interpret UHC? Who maybe have never been in the health center, except maybe as very small kids when they were immunized, but are using health information, mental health support, all kinds of things on their digital devices. And of course, we're not only talking health services, we're talking health information and advice, health education, various health promotion supports, and all of that is now being part of everyday life. As one of our panelists said earlier, people live with the digital, and therefore they also live with health and health advice and health behaviors in very, very new ways. Thank you also for highlighting the infrastructure issues, the need for enabling environments, and what we in the Lancet Commission now call a trust architecture, because we need to respect human rights, we need to support privacy. But we're also introducing a new term through the Lancet work, which we are calling health solidarity, because we've learned in the context of COVID-19, and many of your examples show that we need to find new ways of data sharing in a safe and respectful way, so that our public health instruments are sharpened, and that we can fulfill the social contract. In order to fulfill a new social contract in a digital age, we will need a new use of data and a solidaric use of data. And I think that will be one of the challenges also within our concept of universal health coverage. So without further ado, I'd like to turn to His Excellency, Mr. Kaha Imnadze. He is the permanent representative of Georgia to the United Nations for his closing statement. Please, Your Excellency.
Thank you, Professor Kickbusch. First of all, thank you for wonderfully moderating today's event. Indeed, you've said it everything. You said everything. We had a very interesting discussion. We covered quite a bit from diagnostics to telemedicine to digital divide, various protocols, the COVID angle, the control and enforcement part of it, and of course the privacy related issue. But this is we just scratched the top of it, because with we live in the digital era, and every issue that is pertaining to every other aspect of our life that comes with the digital era relates to health as well. So we are in this process of transformation, and I believe there is much more that can be done through our formats, through this group of friends, and probably we'll have more and more events scheduled, maybe a couple of more events during the course of the remainder of this year and after, and not only to sensitize the wider audience, and particularly our group here within the United Nations, but to show the public real practical benefits of what merging digital and health can do, because our life is merged with digital, whether we like it or not. We leave the house, we forget our wallet, it's fine, but we forget our mobile phone and we all go back because we are attached to it. And that has a lot of benefits and a lot of costs as well. Everything in this world comes with pluses and minuses. Whether we like it or not, this is the world we live in. And I'm a believer in the better part of the artificial intelligence, so that our future will be more secure, will be more prepared for the emergencies that we are facing now, and we can have better development perspectives. This is all I wanted to say. Thank you all very much for your participation on behalf of the group of friends, on behalf of Japan, Thailand, my country, and of course, the WHO, who's been our great partners, everybody who contributed to this event. And thank you again, Professor Kickbusch, for wonderfully moderating our discussion. Thank you.
Thank you very much. Bye-bye, everyone, and see you at the next meeting. Bye-bye.
Thank you. Bye-bye.
Thank you.
Bye-bye.
Bye.